Hello everyone, can you hear me okay? Okay, so I am Ashley Sagan, indeed not Chase. And I was fortunate enough to complete my practicum at the Interior Health Authority in the Office of the Medical Health Officers and Population Health. My project consisted of a proposal for a program evaluation for Interior Health Safer Inhalation Services, which was actually accepted and is currently being implemented, which is exciting. So to begin, Interior Health is the regional health authority for BC's Southern Interior and includes regions such as the Okanagan, Kootenay boundary, East Kootenay, and Thompson-Caribou Shoe Shop region. The public health function of Interior Health is unified under the Vice President of Population Health. And the project I worked on was a collaborative project between the Departments of Clinical Operations and Epidemiology and Surveillance, in which I worked closely with a harm reduction coordinator and epidemiologist. So what exactly are safer inhalation services? Well, safer inhalation services are one of the many harm reduction services offered by Interior Health. The main component of these services is the distribution of safer smoking supplies, which consist of the four commonly distributed items, which we have a glass stem or a Pyrex glass stem or pipe, a vinyl mouthpiece, wooden push sticks, and screens. Another part to these services is there is also information on safer smoking practices and then referrals to care such as addiction or referrals to healthcare. So when first hearing this, you might just see these things listed and think that it is really just another form of drug paraphernalia. So I'll first explain why the Interior Health Authority distributes these items and why a program evaluation was necessary. So as many of you know, disease prevention is one of British Columbia's core functions of public health and includes responsibilities such as disease prevention and surveillance of various communicable diseases. And although the transfer of communicable disease can transfer through various vectors, such as drug use practices and behaviors associated with smoking crack cocaine, these practices increase the risk of transmission. And so some of these things associated with smoking crack cocaine are the materials used to smoke crack cocaine commonly. So hot pipes and different makeshift items such as light bulbs and what other is available to that population are used. And it can actually increase cuts and burns and blisters in the mouth and oral cavity. And so when these open wounds are then paired with different sharing behaviors such as sharing of used equipment or unsafe sexual practices such as unprotected oral sex, there is an increased risk for communicable disease transmission. So to help mitigate these risks associated with smoking crack cocaine, harm reduction programming such as safer inhalation services are implemented. And these services have been documented in the literature to increase access to safer and unused equipment, which then decreases sharing patterns and can also decrease the use of these makeshift equipment and items that increase wounds in the mouth and oral activity. The literature also does explain that access to these services can also reduce injection drug use, which does have very important implications, as we do know that there is increased risks of HIV as well as overdose with injection drug use. So that was another important finding with these services. I do want to note, however, though, that these drug use behaviors and decisions about whether you're sharing a pipe or whether you're choosing to smoke versus injected drug are very complex decisions, and so I do just want to note that it is not directly related to just mere access to these safer inhalation services. So these services, you may have also heard them called as safer crack use distributions or safer crack use kits. They're starting to become a more widely implemented harm reduction program across Canada. And although there has been program evaluations on programs in Victoria, Vancouver, Winnipeg, and Ottawa, there has been no evaluation on Interior Health Services before, which is the biggest piece of rationale for this evaluation. Because there are national and provincial best practice recommendations for how these services are recommended, it was important to assess Interior Health Services and check their alignment with these recommendations. The literature is also very clear and identifies different barriers associated with these services, such as location, hours of service, police interference. So that was another huge piece of the rationale, was looking at interior health services, identifying those barriers, and then maybe seeing what other barriers do exist. And another interesting additional piece of rationale that was identified by community stakeholders and was also supported by the literature is that pipes that are distributed through safer inhalation services can also be blown, like glass blown, into methamphetamine pipes and used to smoke that way, because methamphetamine pipes is not a harm reduction service commonly offered in interior health. So that was something that community stakeholders brought up that they were interested about, because there are obviously risks associated with that practice, and not a huge opportunity to engage with that segment of the drug using population. So that was definitely another important part of this evaluation. So with this rationale, the purpose of the program evaluation is to assess the current state and scope of safer inhalation services in interior health and to determine if these services are meeting the needs of people who smoke drugs. The objectives were to assess, like I said, if the services, assess the current state of services, assess if the services are accessible to the population, both logistically and socially, determine if the services and the supplies are suitable for the administration needs of those who smoke drugs, and to assess if the services are gauging the population and safer smoking education and referrals to care. These objectives were supported by specific indicators, which were then used to design the program evaluation and methodology. And this is just an example here of a poster that went out to different agencies. So the design of this evaluation was a formative evaluation, and in two parts assesses the activities and outputs of safer inhalation services. Activities addresses the current state of services, while the second part, outputs, addresses the outputs and was going to be gauged through the feedback from the target population. So this evaluation is a snapshot of time, and the methodology was processed through Interior Health's quality assurance and project ethics screening tool called ARECI. And we did also make further consultation with the research ethics boards due to the vulnerability of this population, although they had no further recommendations for us to go through. So as I mentioned, part one of the evaluation will address the current state and scope of safer inhalation services. So within Interior Health, we have 19 public health centers and 7 contracted harm reduction agencies that distribute these supplies. But the centers and the agencies do things differently, and they might distribute only one of those 4 key items. They might distribute both of those. They might distribute those via a harm reduction menu. It might come in a kit. So needless to say, there is variability that we wanted to assess and look at. So we designed this online survey via SurveyMonkey that went to the agencies and the contracted agencies and public health centers, and they are to be filled out by either the manager or their most suitable team member. The second part of the survey was a paper survey, and it was distributed to the contracted harm reduction agencies, who are then responsible to administrating the survey to individuals who smoke drugs. So the service providers, using the daily encounters that they already have through the organization, would then approach these individuals, and any individual that has accessed safer inhalation supplies in the last 12 months was eligible for participation. So individuals were to complete the surveys while at the agency, and they're either allowed to go and complete this on their own or with the help of a service provider. It consisted of both an open and closed questions, and there is no personal identifying information available. Those who completed the survey also did receive a $5 remuneration for their time. So the plans for all this information. Well, the knowledge gained from this evaluation, it will provide insight into the current state of services and effectiveness of the services in interior health. Recommendations will be made to the harm reduction coordinator so that they can support these services and also use them for future funding opportunities. And I'll actually be returning next week to present some of the findings to the contracted harm reduction agencies in a face-to-face meeting. And one other exciting part to this evaluation is that we also did have interest from Vancouver Island Health and Fraser Health on this methodology, as they are also looking to do evaluations on similar services. So we've been able to provide this methodology and data collection tools with them, and they're hopefully going to be revising those as they need. So here's hoping that this methodology and those tools will not only be helpful in interior health, but Island and Fraser Health as well. So lastly, I'd just like to say special thanks to Interior Health and the Population Health team. I had an incredible experience at my practicum, and as well specifically to my co-supervisors Jillian Frost and Dr. Sue Pollock. Special thanks also to Nigel Livingston, my practicum supervisor, and my second read-in, Dr. Karen Urbanowski. Thank you, and I'd be happy to answer any questions.
That's such cool work, Ashley. There we go.
you.
Question over there.
I learned lots about drugs. It was fascinating.
I just have a quick question with regards to your survey. So when you had some of the data collected on SurveyMonkey and then some on paper-based, did you have any challenges de-identifying it as you combine the two sets of data, or how did you manage that, just given the different clientele?
Yeah, so this is kind of in the background piece. So both of the surveys did have to go through privacy impact assessments. So in the creation of those data collection tools, there was similar processes, but very different, because one was online for a completely different target group, essentially. And so those both did go through privacy impact assessments, and those are currently being implemented. So I haven't done any data analysis on that yet. Those surveys are currently out right now. But that's the evaluation kind of did happen in part 1 and part 2, because part 1 was very much geared towards the agencies and the public health centers, while part 2 was very much gauged towards that target population.
Any other questions?
Hi, so that was great. Thank you. And I was just wondering what kind of questions you asked. And
Did you have a survey in mind between the service provider or the...
Both.
Both?
I'm just curious what kind of...
Yeah, for sure. So for the first survey, the one that was done by SurveyMonkey, to the service providers and the agencies, some of the questions were mere, what are your hours of services? Or please provide a description of how you provide those services. Do you distribute a kit, or do you do that through a harm reduction menu, as some places call it? And then for the survey that went out to the target population, some of those questions were, how often do you use a pipe? Or do you pick up a pipe from this location? Have you ever been limited in getting a pipe? Have you ever been denied a pipe? Do you feel comfortable accessing these services? So we're really trying to identify if there were any barriers. And another part to that survey was also asking if individuals have indeed blown a crack pipe into a methamphetamine pipe, because that was some of the information that is not well documented in the literature that we were trying to get a better understanding of.
Any other questions? All right then. Thank you, Ashley.
Thanks.